of a segment measures 1.5 times that of an adjacent segment, or if the coronary lumen is clearly irregular. American Heart Association estimated aneurysm were classified as small, less than 5 millimeter, medium, 5 to 8 millimeter internal diameter, or giant, more than 8 millimeter internal diameter. And more recently, body surface area adjusted coronary diameters dimensions were recommended for use mainly for LAD and RCA and left main coronary artery. During echo, we will assess other findings like LV function, regional wall motion, presence of mitral or aortic valve regurg, and presence and course of pericardial effusion. Treatment, initial therapy within 7 to 10 days. We should start aspirin, 80 to 100 milligram per kg per day in 4 divided doses with IVIG 2 gram per kg once. So, if fever persists after 48 to 72 hours, another dose of IVIG. And if fever resolves, we continue aspirin 80 to 100 milligram per kg in 4 divided doses for a period of 3 to 14 days. Then we continue aspirin in a low antiplatelet dose from 3 to 5 milligram per kg per day for 6 to 8 weeks from onset. In patients who didn't respond to a second dose of IVIG, we can go to other medications including pulsed methyl prednisolone or infliximab or other medications including cytotoxic drugs. After 6 to 8 weeks, we will assess the patient by echo. If normal coronaries, no more medications are needed. If abnormal coronaries are found, we give anti-thrombotic therapy. If patient has thrombosis, we give either streptokinase, urokinase, tissue plasminogen activator, coronary angioplasty may be needed, sometimes stent implantation, or we go to surgery like coronary bypass or heart transplantation. If no thrombosis, but patient has definite coronary artery abnormalities, we give prophylaxis against thrombosis. If asymptomatic, we give only aspirin. If moderate to severe disease, we give aspirin plus dipridamole. If rapidly expanding aneurysm, we give aspirin plus heparin. If patient has giant aneurysm, we give aspirin plus warfarin. A patient with Kawasaki disease needs long-term follow-up, even if they have no coronary artery lesion at the beginning. If they have no coronary artery lesion at the beginning, we follow up every 5 years. If they have coronary artery lesion and then disappeared every 3 to 5 years, there are risk stratifications, 1, 2, 3, 4, and 5. This depending on the severity of coronary artery lesion, which one will need catheter diagnosis, which one will need follow-up during yearly or every 6 months, like this. Thank you.
Thank you, Dr. Mohammed, for this nice revision of the subject. We'll allow only 2 questions because of the time. Any question? Yes, Dr. Mohammed.
Yes.
Thanks, Dr. Mohammed. It was a great presentation and fascinating topic. My question is that I know you mentioned there's not much study in Saudi Arabia, but in your clinical experience in Medina region, did you find any cases and how bad the cases are? I'm especially concerned about, do you see any cases with coronary artery involvement?
Actually, in Medina, I work in maternal children hospital. I am here since almost 5 years. We saw a lot of patients. So we found almost, during this period, almost 30 patients. We have 1 patient died from infarction, and we are following now with 4 patients. 2 have dilatation of the coronary artery, and 2 have aneurysm at the beginning. one of them still have aneurysm up till now, and one the diameter of the aneurysm decrease, but still the coronary artery is dilated till now. Two of them we continue for warfarin for a long time in addition to aspirin. Up to now, no need for surgery actually, or intervention even. They are stable. Yes. So, doctor said that he has 9 years patient, have mitral regurg, aortic regurg, and was labeled as rheumatic, but during echo study they found two giant coronary aneurysms, both right and left. Yeah, it's very severe, yes. Yeah. And his age is 9 years. Usually Kawasaki disease is almost 2 to 5 years old, okay? But sometimes it occurs in adults and even in neonates. And usually these extreme types of ages are very severe. Kawasaki disease in two patients is very severe. So your question is concerning, is it acute or chronic? If it's acute, you should find the features of Kawasaki disease like erythema, fever, something is okay. But if it's chronic, you have only the coronary artery abnormalities. But it's very severe to have both. And at 9 years of age? Yeah, maybe, but Kawasaki to have both at this age, it's difficult to have. Yes, okay, Dr.
Dr. Tariq.
Fish mic. Fish mic.
We have the similar problem. We have diagnosed about 3 or 4 Kawasaki disease at children is about 13 or 14 years old. And then we review all the Kawasaki disease in British Columbia in Canada, and we find about 14 patients. And they have the typical feature of Kawasaki. Also, nobody were able to put the diagnosis as beyond the common age. And then we collect all the data and we publish it in Journal of Pediatric in about 1999. Thank you.
Thank you.
I think we need to move. We are late, Mansour. We'll move to the last speaker, is Dr. Amjad Quwatli. Dr. Amjad Quwatli, he is a head section of pediatric cardiology, and is a director of pediatric cardiology fellowship program in King Faisal Specialist Hospital and Research Center. His talk will be how large is this PSD and when to close. Dr. Amjad.
Thank you for the organizing committee for this invitation. I'm going to talk about VSD imaging, then I will touch base on some clinical aspect of VSD. VSD basically is a hole in the ventricular septum between the left and the right ventricle. It's very simple, but it's 20% of all congenital heart disease if it is a solitary lesion. But if you put it in combination of congenital heart disease, probably it's more than 90%. If you notice that the incidence of VSD decrease with age, basically because most of the VSDs will close with time. And it's actually most common congenital heart disease in most chromosomal abnormalities, keeping in mind that 95% of all VSDs do not have chromosomal abnormalities. Now, my topic will go over 5 things. First, I will talk about imaging the ventricular septum, types of VSD, pathophysiology of VSD, when to close a VSD, and methods to close the VSD. Starting with imaging the ventricular septum. First, if you want to look at the ventricular septum, the easiest way is to remove the anterior wall of the right ventricle. In this case, you see that the ventricular septum is basically 4 zones. The first one is this small grayish part, which what we call it the membranous septum. And it's just beneath the papillary muscle of the septal leaflets. Then after that, you have the inlet septum, which is from the tricuspid valve until the papillary insertions of its chordae. Then after that, so this area is called the inlet septum. Then from the inlet septum to the apex is called the muscular septum. Then if you look at this area here, this is the septal band, and above it is the conus. And the part of the conus that separate the right ventricle from the left ventricle is called the outlet septum. So you have membranous septum, inlet septum, trabecular septum, and you have the conal septum. And because the VSD is a hole in the ventricular septum, that means it can be literally all over the place. And based on its location in the ventricular septum, this is the way we nominate them. So if you have a VSD in the membranous septum, we call it perimembranous VSD. If you have a VSD in the inlet septum, we call it inlet, AV canal type of VSD. If you have a VSD in the trabecular septum, we call it muscular VSD, and in the outlet septum, we call it outlet VSD. So now, how can I view the ventricular septum? From parasternal long axis view, you see 3 parts of the ventricular septum. The inner 2/3 is the trabecular septum. Then this 1/3 here is the outlet septum. And there's a tiny small area is basically the membranous septum. But most of us, they don't see the membranous septum here. But when you try to sweep towards the tricuspid valve, you will see it more. From the parasternal short axis view at the level of the aortic valve, this area here is the membranous septum. And you can see that it's underneath part of the right coronary cusp, part of the non-coronary cusp, and underneath the septal leaflets of the tricuspid valve. Indeed, we'll talk about it later, the septal leaflet of the tricuspid valve divides the membranous septum into 2 parts, the interventricular part and the atrioventricular part. Now, from here to here is literally the outlet septum. Now, from the parasternal short axis view at the level of the mitral valve, this whole area here is the trabecular septum, but this part here only is the inlet septum. But if we sweep more towards the apex and you go till the level of the papillary muscles, the whole area here is trabecular septum. Now, apical 4 chambers view, from here till here is trabecular septum. And here is what? Here is basically the insertion of the tricuspid valve near the papillary muscle, what we call the papillary muscle of the septal leaflets. And I hope it's clear for you here, where you can see clearly the insertion of the chordae of the septal leaflet of the tricuspid valve. So this is demarcate the end of the inlet septum. So that's why from here to here is the inlet septum, and from here to here is the outlet, is the trabecular septum. Of course, if you sweep anteriorly until you see the aortic valve, you will be able to image the perimembranous septum. So now moving to the second part of this presentation, which is what are the types of VSD based on their location of the ventricular septum. I will start with the perimembranous defect. Again, the membranous septum is from here to here, underneath the septal leaflet of the tricuspid valve. And any defect in this area, we label it as perimembranous VSD. And it's more pronounced here. You see, it's a small area here, but the VSD is bigger than the usual membranous septum, and that's why we call it perimembranous septum or paramembranous septum, which means it doesn't involve only the membranous septum, but it goes and eats some of the adjacent septae. In perimembranous septum, it's frequently you see some tricuspid valve abnormalities, and the most common abnormalities is a redundant tissue that comes from the septal leaflets and insert on the edge of the VSD, and that's what we call it an aneurysm. And this aneurysm is beneficial to us in two ways. First, it restricts the flow from the left ventricle to the right ventricle, and hence this VSD will become restrictive, and the patients hopefully will have less symptoms. And also, it's part of the closure mechanism. So if this tissue increases in growing, eventually, hopefully, it will close the VSD. And the third thing is that I can use this aneurysm to harbor a PFM coil to close this VSD. Now, the membranous septum, as I said, has two components. And this is a pathological specimen. This is the membranous septum, and this is the septal leaflets of the tricuspid valve. And you can see that membranous septum has two parts. The first part, which is between the left ventricle and the right atrium, and we call it the atrioventricular septum. And the second part is between the two ventricles, between the left ventricle and the right ventricle. And to show this to you, I chose this patient who has an ASD and a dilatation of the right atrium. This way you blow this area very nicely. So you can see here, this area here is the interventricular septum, but this here, this area between the hinge point of the septal leaflet of the mitral valve and the hinge point of the septal leaflet of the tricuspid valve is the atrioventricular septum. And a defect in this area here will end up in a jet from the left ventricle to the right atrium. And you can see here, this is the septal leaflet of the tricuspid valve, and you can see the jet is here. And that's what we call it, the Garbuti VSD. Now moving to the muscular VSD, it's located in the muscular septum, inferior and anterior to the inlet VSD. And usually the septal band separates it from the outlet septum. It accounts for about 5 to 20% of all VSDs, and it has mainly four types: anterior muscular, mid-muscular, posterior muscular, and apical muscular. And of course, the multiple VSDs, it can be the combination of all of the above. An example of that, this is the patient with mid-muscular VSD. And again, this is the inlet part of the septum. This is the trabecular part of the septum, and you can see that this patient has a VSD that's exactly in the middle of the ventricular septum. So that's what we call it mid-muscular VSD. Another example here, if you tilt your transducers and you tilt your hand anteriorly, you will be able to show the outlet muscular septum. So this patient has an outlet muscular VSD. Be careful about that because sometimes it gets confused with malaligned VSD. And probably those two is a spectrum that you can have VSDs in between. Now this is another example of apical VSD and multiple VSD. So this is an apical VSD. This is almost a mid-muscular VSD. And you can see the shunting here. It goes from the right ventricle to the left ventricle. Now, outlet VSD. Outlet VSD, again, to remind you that this is at the level of the aortic valve. This is the membranous septum here, and this is the outlet septum here. So any defect in this area here, we call it outlet VSD, or we call it supracrystal VSD, subarterial VSD, and you name it. It has so many names. The importance of this VSD is one, extremely rare that it will close, and that's what we call it the Asian type of VSD. And also the jet of VSD usually hit directly the pulmonary valve, and it can affect the pulmonary valve. Also this VSD, 6 to 9% of those VSD, they have a prolapse of the right coronary cusp across it. The pathology of this VSD is, we call it absent of the outlet septum. Some people, they believe total absent of the outlet septum, and others, they believe it's partial absent of the outlet septum. Now, there is another abnormality in the outlet septum, what we call it the malaligned VSD. And again, we go back to the original echo in the normal patients. From here to here is the trabecular septum, and from here to here is the outlet septum. So if there is a break here and the outlet septum move in a way that it's malaligned with the trabecular septum, in this case we call malalignment between the outlet septum and the trabecular septum. An example of that is here. This is part of the outlet septum that is not aligned with the trabecular septum, and you have overriding of aorta. And this patient has malaligned VSD. Of course, if you move towards the pulmonary valve and you have pulmonary stenosis, this is tetralogy of Fallot. But if you do not have pulmonary stenosis, this is what we call it the malaligned VSD or the Eisenmenger VSD. And extremely important to differentiate it from tetralogy of Fallot. Now, if the outlet septum, which is here, deviated posteriorly, creating an obstruction in the left ventricular outflow tract, this type of VSD, we call it malaligned VSD with a posterior deviation of the coronal septum. Compare this patient with this patient here. This patient, most of the time, they have an isolated VSD lesions, but this patient rarely have an isolated VSD lesions, and whenever you have this, you have to look for interrupted aortic arch, you have to look for coarctation of aorta, or probably in a more complex patients, you have to look for the whole spectrum of Sean complex. Now, inlet VSD, it's located in the inlet septum. And again, you can see the septal leaflet of the tricuspid valve, and there is a chordal insertion to the crest of the ventricular septum, and the VSD is located here. In inlet VSDs, some people believe it's not part of the AV canal complex. Others, they include, especially the British literature, they include it in the AV canal complex. But most of the literature, they said it's a separate entity. Very frequently, you see overriding of the tricuspid valve. So if this is the ventricular septum, if you create a line here, from here to here, you can see that there's some overriding of the tricuspid valve. And sometimes you can see straddling of the tricuspid valve. In this patient, there is no straddling, but you can see there is crestal attachment of the chordae. Now, moving to the third part of the presentation, which is pathophysiology of VSD. If you have a VSD, you have left ventricle to right ventricle shunt, and that's what we call it left to right shunt. But what are the factors that affect the left to right shunt? The most important factor is defect size. If you have a small size, it will restrict the flow. But if you have a medium size, that means it's less than half of the aortic diameter, and there is some restrictions to flow. But if you have large defects, there are absolutely no restrictions of flow, and the blood can freely go from the left ventricle to the right ventricle. In this case, you go to the next important factors that affect the shunting, which is the relationship between the systemic and pulmonary vascular resistance. If the systemic vascular resistance is higher than the pulmonary vascular resistance, the blood will flow from the left ventricle to the right ventricle. And if the pulmonary vascular resistance is higher than the systemic vascular resistance, the flow will flow from the right ventricle to the left ventricle. And most of the times, the systemic vascular resistance is much higher and the pulmonary vascular resistance is much lower. So in this case, most of the blood will prefer to go from the left ventricle to the right ventricle. And the blood eventually will go to the lungs. And the lungs will harbor probably 4 to 5 times the amount of blood that usually handle. So you have increase in the pulmonary vascular markings. The blood will go again to the heart. There will be dilatation of the left atrium. There will be dilatation of the left ventricle because it's handling more volume overload. So you end up with a vicious cycle. There will be more blood flow, more dilatation, and eventually you have this horrible X-ray, which is significant dilatation of the heart and significant increase in the pulmonary vascular markings. Now, if the child has a congested lungs, he has to breathe. And we all know that the child is not a nasal breather, which means is the nasal breather. But sometimes, if he's really tachypneic, while he's feeding, he has to stop, take a breath. And this is the perfect time when he will aspirate. And that's why most of our VSD patients, they present with recurrent chest infections, especially in the right upper lobe, which is secondary to aspiration. Now, if you have increased work of breathing, we know that breathing is probably account for 20% of your insensible loss in a respiratory rate of 40. But what about if you have a respiratory rate of 80? That means your insensible loss will increase from 20% of your daily allowance to 40% of your daily allowance. That means you lost 20 to 40% of your caloric intake. Now, there is an increased caloric expenditure because also the muscle has to move your chest. And also you have recurrent infections because of, because of congested lungs. All of those, eventually they will call failure to thrive. Now, failure to thrive, that means you have less protein in your blood. That means you have decreased immune system. And decreased immune system, basically you'll end up with recurrent infections. And you end up with this vicious cycle that it doesn't finish, and you have significant failure to thrive. Now, if you don't treat this patient will die mostly within the next probably 1 to 2 years. But some of them, they don't die. Why? Because of the body will defend itself. How it defends itself? The VSD is causing too much blood going to the lungs. So the lungs will defend itself by what? By restricting the amount of blood going to the lungs. So there is distal migration of muscles, there is intimal proliferations, there's medial proliferations, and literally there's a blockage of distal arteries. And that's what we call it, the distal pruning. So the body by defending itself, it pruned the distal arteries. But that's not good, because that means the proximal arteries will become dilated and hypertensive. And this hypertensive pulmonary arteries, and at that stage we call it the pulmonary vascular obstructive disease. This hypertension will reflect it on the right ventricle by increasing the right ventricular pressure, and at that time, the shunting from left to right will be reversed to shunting from right to left, and that's what we call it Eisenmenger syndrome. When Eisenmenger starts, you have significant cyanosis, and you'll have the complication of cyanosis, which is clubbing and bleeding tendencies, and etc. So you have to treat the VSD by closing it. Of course, we don't close a small VSD or tiny VSD. But when do we close it? We close it when we are failing to treat this patient. For example, if you have failure to thrive, you have recurrent pulmonary infection, the patient is not gaining weight, so you have to close this VSD. But also, I will close a VSD that is large, but no symptoms. The reason for that, because those patients, they have high PA pressure. And what we call the persistent high PA pressure after birth. And those patients, they have to close. And also, I close an asymptomatic patients when I cath them and I notice that there's a QPQS of more than 2 to 1. By the way, this counter is not right. It's going off the wall. So I'm keeping going. Anyway, another indication to close a VSD, if I develop aortic cusp prolapse. How does it happen? If there is a shunting from LV to RV, sometimes it sucks the right coronary cusp most of the time. Then eventually it pushes it. Then with every diastole, it pushes it again. So if this cusp continues to protrude into the right ventricle, we call this prolapsing of the coronary cusp, and that's an indication in some centers, immediate indication to close the VSD. Another example, this is an example here. It disappeared. Anyway. So this is the cusp here, and eventually you think there is no VSD, but there is a VSD. This cusp is closing this VSD. And when the surgeon opened up this patient, the whole area was a VSD, and this whole area is a cusp that's closed the VSD. Now, how to treat the VSD, how to close a VSD. We can do PA band, surgical closure, transcatheter closure, and hybrid closures. PA band, rarely we use it these days, but it's restricted to patients who have less than 2 kilos, critically ill newborn, multiple VSDs, VSD with associated anomalies such as straddling of the AV valve. And you can see this is the PA band here. But most of them, they go to surgical approach, which is usually transatrial in inlet and perimembranous VSD, and transpulmonic in outlet VSD. You can go to the cath lab and you can close the VSD especially muscular and perimembranous VSD with an implanter, despite some people is shying away from the perimembranous VSD. You can introduce your implanter from the aorta, or you can introduce your implanter from the IVC. You can put, usually we take a look at it by echo, and you can see the implanter here is encroaching on the tricuspid valve, so we have to reinsert, we pull back the implanter, then apply it again. You can use the PFM coil, and again, for the PFM coil, you have to have aneurysm, and this is the echo how it showed. And finally, the hybrid closures, and right now probably it's restricted to mid-muscular VSD in a low weight, for example, less than 5 kilograms. We have 2 cases recently in our centers. So I conclude my presentations with a chest X-ray. This is the chest X-ray of a large VSD before, and this is chest X-ray with a large VSD after. Thank you very much.
Thank you, Dr. Amjad. I think we'll move the question to the end of the second session since it's an imaging in congenital heart disease. And now we'll start the second session, and the chairperson is Dr. Abdullah Al-Jarallah and Dr. Riyad Abu Sulaiman.